In this episode, I would like to briefly discuss the apnea of prematurity versus breath holding spells and introduce methods in their differential diagnosis from one another and from seizure, and finally discuss their management options. What are breath holding spells? These are episodes of apnea that's usually precipitated by pain, anger, or some frustration, one way or other, while the other physical exam is normal. What's the significance of age consideration? Most common age of breath holding spells is 6 months to 5 years, and the significance is this is exactly the same age where simple febrile seizure is common, so we need to differentiate these two conditions from one another. What is required for the diagnosis? Normal physical exam. If all these criteria are met, what's the management? Reassurance and no other treatment needed. What is required for parental education? They should know that there will be no developmental negative consequence to this. No treatment is needed. These breath holding spells may occur up until age 5. They may have a recurrent nature. And later in life, they may be associated with vasovagal syncope. Okay, there are two types of these breath holding spells. What are they? They are either cyanotic or pallid. That's the child is either getting cyanosis or becomes pale. What are the hallmarks of the cyanotic type? In the cyanotic type, during the crying and breath holding, there will be forced expiration. This forced expiration is followed by apnea and some degree of limpness and possible loss of consciousness. What is the hallmark? The hallmark is no trauma was triggering the event and the return to baseline is rapid. Now, what are the hallmarks of the pallid type breath holding spells? There could be a minor trauma trigger. The breath holding spells and possible loss of consciousness are associated with pallor and diaphoresis. However, this whole period lasts less than 1 minute, but important is that there may be some brief episode of confusion and slippiness for a couple minutes. Again, this episode of confusion and drowsiness is just a couple minutes, not longer, and that will help differentiate it from seizure when we discuss later. So that is very important. Now, we mentioned that this pallid type breath holding spell could be associated with some minor trauma. So this is the moment we need to discuss the differential diagnosis of breath holding spells. Of course, we mentioned seizure. However, what about the trauma? For example, brain injury. Remember that in traumatic brain injury, there is a history of serious, not just very minor trauma. So that is the strongest clue. And what would be the next step? We need head CT. The next important differential of breath holding spells is seizure. Now remember that in seizure, there is no provocative event, either crying or minor trauma. Yes, seizure is possible after major traumatic brain injury, but most of the seizures that are the differentials for breath holding spells are those silent seizures which are not triggered. So we need to not only rely on the absence of minor trauma, absence of crying and forced expiration, but also we need to analyze the loss of consciousness and the post-ictal phase. Always remember in breath holding spells, if loss of consciousness happen, it won't last longer than 1 minute. And second, in the pallid type that we discussed, some degree of confusion and drowsiness is possible after the episode. That period of confusion and drowsiness is also just very short, if present at all, not beyond a couple of minutes, while the post-ictal of the seizure is much longer, loss of consciousness longer, other physical exam findings, abnormal neurologic exam, etc. are present. What's the third important differential diagnosis with breath holding spells? That is congenital heart diseases, especially the cyanotic type. So how do we differentiate that? Well, most of these congenital heart diseases are associated with tachypnea and some symptoms of heart failure, such as feeding intolerance and diaphoresis. Remember, patients with breath holding spells may also have diaphoresis, but during those episodes of crying or after minor trauma. Also, there will be some murmurs that's audible, and most importantly, and we discussed it in our episode on approaching child with cyanosis, is that the heart disease causing cyanosis is not responsive to oxygen therapy. So a vignette in this moment could be very relevant. So you have a child with some breathing abnormalities and some degree of cyanosis or blue-gray discoloration. How do you approach this child? Well, if breathing abnormality is more in the form of breath-holding spells with some triggers, and if we do not hear any kind of abnormal cardiovascular auscultatory finding, that's most likely breath-holding spell. However, if we hear some murmurs, again, not just a simple physiologic murmur, such as a systolic ejection murmur, then we need to do workup for congenital heart diseases. We may also consider a trial of oxygen therapy, oxygen supplementation, to see if the cyanosis responds to it or not. If there is no response to cyanosis to oxygen therapy, that's the cardiac nature, and we need to perform echo. Now, this looks like a little bit of a busy slide, but because of its importance, I would like to more clearly discuss the ways to differentiate breath-holding spells from seizure. Always remember the risk factors is a very important clue in the entire process of differential diagnosis in medicine, and unfortunately, I feel it hasn't been emphasized enough. I haven't seen a book that just discusses the significance of risk factors on differential diagnosis. But again, risk factor for breath holding spell could be absent, but if there is any, it's usually iron deficiency, anemia. For the seizure, it could be, again, no risk factor or presence of febrile seizure in the history or some sort of developmental delays or neurodevelopmental disorder. Then, in addition to risk factors, we have triggers. As mentioned, crying, stress, frustration, or minor trauma could be the triggers. Usually seizures are not triggered. However, if you are asked what are the possible provocative factors for provoked type seizures, remember fever as well as sleep deprivation considered triggers for seizure. Now we discussed that the duration of loss of consciousness and the post-episode period is longer in seizure and it's shorter in breath-holding spells. Again, loss of consciousness, if present at all, it will be less than 1 minute. Post-episode drowsiness is less than 5 minutes in breath-holding spells, while in seizure, both of these are longer. And then we have the central core symptoms of each one of them. For example, symptoms of breath-holding spell is either the pallor in the pallid type, which could be associated with bradycardia, or apnea in both types, and cyanosis in the cyanotic type, versus we have the neurologic deficit, abnormal movement, and other findings associated with seizure. Even EEG could be provided as normal or abnormal, and the duration of post-ictal, etc. Okay, now let's discuss apnea of prematurity. It has very precise definition and timing requirement that needs your attention. So, first of all, it's more common among premature infants. The preterm infant is otherwise healthy. Between the episodes, doesn't appear sick. Will manifest these episodic apneas. These episodes are associated with decreased heart rate for the age and decreased oxygen saturation. And most importantly, these won't happen after first week of life. They are most common in day 2 and 3. But if you have these happening after first week, you cannot diagnose the condition with apnea of prematurity. Again, what's the most important risk factor? Prematurity, and there is linear relationship with the degree of prematurity. Increased prematurity is associated with increased risk of apnea, to a point that extremely premature infants born before 28 weeks gestation are almost always have this apnea of prematurity, and the mechanism is this immaturity of the central respiratory areas, the respiratory centers. Now, what is the diagnosis and workup or management? Diagnosis is clinical, exactly if all these criteria are present, and management is reassurance if no other risk symptoms are present. I cannot emphasize enough on our understanding of risk symptoms in a premature infant with apnea. If any of these are present, the management is not reassurance anymore, and we need to perform further workup. So what are the risk symptoms in a premature infant with apnea requiring further workup? If we have this new or sudden onset apneic episodes or apneic episodes that last beyond first week of life, if we have severe episodes, for example, the episodes that require resuscitations, if the infant appears ill between the episodes, and finally, if we have a term infant with new onset apnea. All these conditions require further workup for assessment of apnea, for assessment of possible cyanosis, and other respiratory or cardiovascular disorders based on the other findings you are provided. We are not going to discuss that. We are just saying that this list provides us what not to miss if a premature infant or an infant overall has apnea. We cannot manage with reassurance alone if any of these are present. So master these, please. Now we need to discuss the differential diagnosis considerations in apnea of prematurity. And the first differential consideration is breath holding spells, especially the type associated with bradycardia. Why is it so? Because as we discussed, it's the palate type or trauma, minor trauma related BHS that could cause also desaturation and decreased heart rate. So how do we differentiate these conditions? You need to follow the exact formula of apnea of prematurity to be able to do this differentiation. Again, first week of life, episodic apnea, premature infant, cessation of breathing lasts more than 20 seconds, and the neonate appears normal between the episodes. These are in favor of apnea of prematurity. If they are triggered associated with pallor or cyanosis, again with presence of trigger, those are breath holding spells. Usually breath holding spell is not a diagnosis of prematurity. Second differential is intraventricular hemorrhage. Why intraventricular hemorrhage is an important differential of apnea of prematurity? For two reasons. Simply, it's associated with apnea and it happens in premature infants. So what we need to do? Even though a strong clue for differentiation of IVH from apnea of prematurity is that the premature neonates with apnea of prematurity are well, otherwise healthy looking between episodes, and that's not the case with intraventricular hemorrhage. If there is diagnostic challenge, you have to perform cranial ultrasound. Always remember, if we have a neonate with apnea and you have no other clues provided, and you have just to pick one test, that test will be ultrasound of the cranium. And all I'm saying is, if you do not have any other clues to favor any of the other differentials with their possible needed workup. Another important differential of apnea in premature neonate is all the causes of respiratory distress in neonatal period that we talked about, including neonatal respiratory distress syndrome, bronchopulmonary dysplasia, especially the ones like these two that are associated with prematurity. Now, how do we differentiate them clinically? Again, the neonate would not appear normal or healthy between the episodes of apnea, but will have this continuous worsening pattern of respiratory distress. And again, when that's the scenario, what will be the next assessment? We need to perform assessment for sepsis, perform chest x-ray, and if possible, more imaging studies. Now, if we have this neonate, again premature or mature, with apnea period and possible temperature instability or vital signs abnormalities, what are you thinking about? We are thinking about sepsis and other overwhelming infections such as meningitis. We need to perform cultures and detect the possible source of infection. And finally, the same way that seizure is a differential of breath holding spells, seizure can also be associated with apnea, and so we need to be able to differentiate it from apnea of prematurity. Again, both conditions can also be episodic sometimes. However, abnormal neurologic exam and presence of post-ictal phase could be in favor of seizure. Now, if you have abnormalities in ultrasound in a neonate with apnea, what are the possible differentials? Well, if you see echogenicities within the ventricles, that will be intraventricular hemorrhage. But if you find any other type of abnormalities in central nervous system in a child with episodic apnea, what is the diagnosis? Presence of ultrasound abnormalities other than those of IVH in a neonate with apnea favors seizure, unless if you have very specific finding that favors a very specific neurologic neurodevelopmental disorder. Thanks. This finishes our discussion of breath holding spells, apnea of prematurity, and their differential from one another and from seizure.